Guscha Artem Olegovich, minimal invasive surgery of the lumbar spine.
Thank you, Mr. Chairman. I'm very happy to be here, and my special greetings to Professor Teixeira, who has only reached Moscow this time. I hope your prominent act will be signed in the history of Brick Spine. But anyway, I like that Professor Konovalov, who suddenly disappeared, to start a discussion regarding some minimal invasive surgery for oncology, extramedullary tumors. I want to follow with this surgery for spinal stenosis process, especially for lumbar spine. And And we all know that some kind of algorithm already exists in treatment of stenotic process. For this theme, we actually follow the idea that it doesn't matter what's provide compression. It's very important that we stay in the position of minimal invasive decompression, and just having this process, we can perform the compression based on the idea that different kind of stenosis is actually anatomical landmarks of the spinal canal, and if the central anterior-posterior diameter less than 10 millimeters, it's stenotic process. If it's lateral canal less than 2 millimeters, it's lateral stenosis. So we can subdivide the stenosis on the actually on cervical or on the lumbar level according to this anatomical landmark, and to provide them some minimal invasive decompression in case if you don't need to provide the stabilization, and if there is no real instability, which of course needs additional instrumentation to treat such kind of patients. And also we all based on the well-known anatomical classification for stenotic process as SHIZAS, which already 10 years old, and which based on the ratio between nerve structure, liquor inside the spinal canal, and subdivide the degree of stenosis for 7 rentgenological classification, and you can understood what's the level of stenotic on the certain level. I like that now we have the nice stenosis algorithm, which actually it's provided by Timothy Deere groups, and it's already include the consideration to perform minimal invasive decompression on the left side. You can see if it's a stable central lateral stenosis process, you can perform the direct decompression, which we actually discussed now, or indirect, like X-leaf, just for stretching the yellow ligament. It's also very attractive minimal invasive procedure, which could be done with some lateral approach, minimal invasive. So we also create some kind of minimal invasive algorithm, which subdivide the process according to anatomical landmarks of stenosis. Central, if it's density of the compressive structure like osteophytes, it's another procedure which normally done via portal navigation approach. And finally, we are going to some algorithm, anatomical, very easy used for the young surgeon algorithm, which combine the clinical science with monoradicular, with, let's say, lateral stenotic process. We are doing normally transforaminal approach. It could be TESIS, as the JOIMAX suggests, but it also can be posterolateral procedure, which just need to be cared with the navigation, positioning of cannula in the right way, and then it's not very easy, but after a certain learning of the understandable procedure with removing of annulus fibrosis and a procedure named in-out, so via disc we are going inside the spinal canal, removing the herniation, checking the position of passing and transversing nerves, and then finally 90% you have a reduction of pain and nice view on the MRI. it's lateral recess stenosis, for example, or even soft herniation. But now, due to a very severe quantity of patients which have osteopenia with long process of stenosis, with central stenosis, the percutaneous procedure for the severe stenosis also very popular, and we increased the amount of this procedure in our institution 2 times now at 50-70 procedures per year. And there are many different approaches. We actually use the so-called ELESIS or Delta approach, but it's a lot of variants. You can use even K-leaf, so-called, when instrumentation, additional instrumentation via percutaneous approach also can be applied. So ELESIS in case of central or severe lateral stenosis could be performed, and you just limited intralaminar space. And what's important in this situation, you always use the same instruments and generally the same anatomical landmarks as you perform when you perform open approach for the stenosis. So it's next slide. Can you click on the video, each of 3? And theoretically, you are doing the same procedure as when you're doing the open. So you position on the cannula, you are drilling and a little bit increasing the intralaminar space, and you start to remove yellow ligament. But you're doing in constant irrigation. You have only 1 to 5 millimeter stitch incision, and you don't need to perform any bleeding correction. And actually, you even wouldn't care for the laceration of the. Can you click again? Кликните на изображение. And you can even see the unilateral radicular, and the same easy way you can see the contralateral radicular using the over-the-top technique, because you can reposition the cannula all the direction inside this interlaminar space. So the let's say a learning curve for this procedure, it's, I would say, even easier than for thesis, because all the structure is very seeable and very understandable. And what's important, I probably will show it on the cervical level, and you having the pressure of water, you can always a little bit detach the dura from the yellow ligament and avoid any laceration. So finally, you always have the minimum 100% increasing of the transverse area. It's 1.5 centimeters, so it's really normal spinal canal. You normally have the good clinical results. Here's just it's one of the first trial when we start to perform percutaneous endoscopic decompression for cervical stenosis. But of course, it's a little different because you have drilled a lot, and you always should avoid bleeding, because the vein which located epidurally provides some difficulties to detach the radicular from the herniation. But in general, the procedure is the same, and it's always the tricky to provide the right direction of this drilling, because you have to little bit move the radicular and to detach and remove the normally soft herniation from the radicular. It's quite similar to the procedure which we are doing on the lumbar way, but instruments is smaller than a lumbar level. So finally, having percutaneous endoscopic procedure, we reach the early rehabilitation for the patient. Minimal bleeding. 1 day after surgery, they stay at hospital, and the results is quite promising, because next day they can ready to go home, and 3 weeks they can completely social rehabilitated. Of course, we have some contraindication, but it's quite critical. Severity of stenosis, osteophytes, some very severe neurological deficit. Probably if you have claudication, patient is stop moving, you will perform the severe and very extensive decompression. But in general, this procedure is available for all kind of the stenotic process, lateral, central, cervical, lumbar, depending on the instrumentation you have, and just you need enough interlaminar approach to position your endoscope in there. Just some figures at the end, that the pain is disappeared first day, and having 70 patients, we haven't the recover or return of the pain, and just promising result for ODI and McNabb score. Learning curve, that's discussable. Our international friends recommended 70 procedure to reach the level of 60 minutes procedure. So after 60 procedure, you will perform the operation for 1 hour. Yes, probably it's reasonable, but for stenosis, I think it's 20 procedure, it's enough, and you will be the expert. And to conclude, I think the minimally invasive way very attractive for the and as an alternative for the open procedure, and percutaneous endoscopic irrigation procedure is very nice and very future for this kind of degenerative disease. Thank you.
Thank you very much. Вот два вопроса, Артем Олегович, к вам есть. В каком возрасте чаще всего встречается стеноз поясничного отдела позвоночника, и какие сопутствующие заболевания этому способствуют?
Курение, Сергей Васильевич, курение, алкоголь. Это шутка, конечно. На самом деле мы считаем, что стеноз выраженный хирургически начинается после 65 лет. Наш контингент это 65-75. Мы почти всегда имеем больше женщин, примерно 70%, и он сопровождается развитием остеопении или остеопороза. Поэтому мы часто и идем на эти операции малоинвазивно, потому что какая-либо инструментация в данном случае невозможна.
И второй вопрос. Вот какая тактика при повреждении дуральной оболочки или квары? Вот это прекрасный вопрос, самый лучший, потому что никакой. Если перкутанной операции у вас появляется дырка в оболочке, что, конечно, возможно, и у нас она появляется, и вы видите вылезший даже фастикулу, вы просто ее тампонируете и спокойно закрываете рану. Мы проверяли, после этого максимум, что вы получите, это очень небольшая, меньше сантиметра кубического киста, потому что разреза нет, мышцы все сохранные. Это, кстати, большое дело. Мы сейчас проводим исследования состояния мышечной ткани после перкутанных операций и надеемся, что это выльется в определенную стратегию такую достаточно масштабного плана. Спасибо большое.
Спасибо.
Следующий доклад Дмитрий Александрович Пташников. Surgical treatment of metastatic